All right, everyone. So we are about at time. It's 9:20. So I would like to invite Vanessa Vincent up to give her presentation on the benefits of enteral nutrition for cancer patients. So if you would like to help me in welcoming Vanessa today.
Good morning. Thank you all for being here. As Grace said, my name is Vanessa Vincent, and I am presenting on the post-operative effects of early enteral nutrition in cancer patients. I will be discussing enteral nutrition and some other topics regarding different ways of administration routes, but the focus definitely will be on early enteral nutrition. So just giving that heads up here. Oh, thank you.
Yeah, no problem.
So just a little overview, we're just going to be talking about the etiology of cancer, common treatment options, who benefits the most from that early enteral nutrition that we're going to be focusing on. The second part of this presentation, we'll be going over 3 different studies. The first one, I just want to talk about the benefits of enteral nutrition as a whole in general before I dive into the early enteral nutrition. The second study will be the early enteral nutrition benefits for GI cancer patients. And the third will specifically focus on cancer patients who have esophageal cancer or head and neck cancer. And then we'll have a little discussion if there's any questions or things you guys want to talk about. So going on to our first part of this, what affects cancer? So there's not just one thing that can affect cancer. It can be genetics, environment, lifestyle, diet, all these different things can accumulate to things that affect cancer and cause cancer. So the different treatment options, as you can see, if there's surgery, radiation, chemotherapy, immunonutrition, but a lot of times these different methods are worked in combination. So people won't just have one form of treatment, they tend to have more than one working together. The downfall of those treatments, even though they're very helpful, they get to get rid of that cancer, there's a lot of side effects. Malnutrition being one of them, and that affects weight loss, length of hospital stay. It affects recovery time, immune function, and overall survival rates. So what can we do to assist with those issues that the treatment causes? So ways of administration for food is one way that we can help those effects of cancer. Getting in adequate nutrition, whether that be oral intake, which all of you know, eating by mouth, but sometimes that can be affected depending on where your cancer is located. So thinking about those head and neck cancer patients, if it's bilateral on both sides, that cancer might be affecting things, you're not going to be able to swallow your food. Enteral nutrition, also known as tube feeding, a way of delivering nutrition directly to your stomach or small intestines. And you might need this if you're not able to get enough calories in by mouth. And a lot of these times too, these methods go hand in hand, just like the treatment, how there's a combination. Feeding administration also tends to go have combinations as well. So taking things in orally as well as maybe tube feedings. So our biggest focus, early enteral nutrition, I have that star there. There is the initiation of enteral feeds within 36 hours of admission to the hospital or 36 hours before surgery. And then on top of that, there's even an administration several days before surgery. So it's kind of an iffy definition, but that is another way of getting calories in. So another option, parenteral nutrition. You're going to hear a lot of these definitions too used throughout the research studies. So just putting a pin in these as well. Intravenous administration of nutrition. So may include protein, carbohydrates, fats, minerals, electrolytes, vitamins, and other trace elements. And as you can see on the left picture there, it's being administered through the arm, and then on the right, there can be like a port in the chest. So again, who benefits the most from our early enteral nutrition? Nutrition prior to surgeries, to treatment, things like that. Well, it's going to be those head and neck cancer patients that's going to affect their ability to consume food orally. They are at higher risk of all those different things: malnutrition, weight loss, length of hospital stay, and mortality. So on to the review of the studies, diving in deep here. Effects of enteral nutrition and parental nutrition, along with a control. So the different objectives of this study was just to evaluate the effects of enteral nutrition, parental nutrition, and that control in a palliative care unit. The methods of the study, they collected data of primary nutritional administration routes during the first week after admission, which was oral intake, enteral tube feeding, parenteral nutrition, parenteral hydration, and poor oral intake. They further broke those groups down into 3 specific ones, and you can see our participants, the 1, 2, 3, enteral nutrition, parenteral, and control. And you'll be able to see that in those graphs that we'll be posting later. So after the investigation of the implementation of the artificial nutrition and hydration, participants were further divided into those 3 groups according to the nutritional administration route and calorie sufficiency rate total. The results were that there was a lower risk of mortality observed in the enteral nutrition and parenteral groups, enteral being above all the others. So this is just an overview of the characteristics of the subjects. And you can see it was first broken down into the 5 different categories before it ended up in those 3. But I wanted to put a big star here because you can see that this was at the baseline before they gave any kind of nutrition. And there was severe diagnosis of malnutrition. So if these people would have gotten early enteral nutrition, things may have been different, but just pointing that out. Also, body weight loss was significant. A lot of these patients were underweight prior to getting their nutrition administration. And the albumin levels were definitely a lot lower. So here we go in those 5 different groups. The 3 boxes that have the rectangles around them, they're highlighted in blue here. Oral intake, enteral feeds, and parenteral, they all had moderate to high calorie intake, whereas parenteral and poor oral intake had the low to very low calories. We then broke that down into the 3 different groups, enteral, parenteral, and the control. And you can see along with the calorie sufficiency rate totals. So there was a nutritional administration route and calorie sufficiency rate total intake hazard ratio performed for the mortality. And the data show that there was a significantly lower risk of mortality observed in the enteral nutrition and the parenteral nutrition groups over the control group. This one as well. It took the comparisons between the 3 different groups, and there was a significant finding in the survival rates between the 3 different groups, enteral being higher than the control and parenteral as well. So the strength of the study, it was non-biased, wide variety of characteristics that were used, and it followed the guidelines for EPIC. Weaknesses were that a lot of different populations were not factored into this study for weight loss considerations. There was changes in nutritional support closer to death that were not observed. And blood tests and body composition were not measured and things like that. So on to our second study. This looks into the early enteral nutrition. So in those esophageal cancer patients. So the objective was to evaluate the impact of the program on the length of hospital stay, the days to the initiation of the diet, and post-operative weight loss, as well as post-operative morbidity and mortality. So the methods of the study were that all participants had to have went under the surgery, the Ivor-Lewis esophagectomy, and I will show you a picture of that and kind of explain what that surgery consists of. And then the patients who underwent the surgery after the implementation of this protocol through September 2017 through August 2019 were then compared with patients who underwent the resection before the protocol implementation. So January 2015 to 2017. First, we have our pre-protocol group. So they had the surgery before enteral nutrition. And our post-protocol group, they had the surgery after enteral nutrition. So, and I put big stars by these two so you can know which is which. It kind of seems a little confusing because the wording of that. But post-operative, they definitely received the enteral nutrition before getting that surgery. And the results, there were significant findings that early enteral nutrition was able to prevent the unintentional weight loss and improve post-operative outcomes. So here we have the esophagectomy. And as you can see, the stomach is not taken away, it's smaller, and then it's also brought up the esophagus as well, so a bit higher up. So here I have that big star next to our post-protocol group. These are the patients who first had that early nutrition, enteral nutrition, and then they had gotten their surgery. So at baseline, there was no significant differences in the patient demographics, smoking comorbidities, disease characteristics, anything like that. The majority of the patients were severely malnourished. So here we have a summary of the characteristics. So significant differences were observed in the approaches between the two groups. So after they took this whole population, they realized that there was less minimally invasive approaches used in the post-protocol group, which was the group that received early enteral nutrition. And there was also delayed gastric emptying in the post-protocol group as well. So what they wanted to do was set these two groups apart to make sure there was no biases. So this one included all the patients, even with the minimally invasive surgery. And the median length of stay was significantly shorter, as well as days to initiation of the diet, shorter median time of the feeding removal, and length of hospital stay. So next, they wanted to consider taking away those minimally invasive approaches and focus on all the subjects who didn't have that minimally invasive approach, just because that might affect infection rates and things like that. So, limited to the minimally invasive patients only, they still found significant findings in the early enteral nutrition group. So that post-protocol group had better outcomes of all of the same things: days to initiation of the diet, days to jejunal removal, weight loss, and length of hospital stay. So overall, I gave this study a B. It's a positive rating. And the strengths were that it followed the ethical guidelines, there was no conflict of interest, and they continued the follow-up with patients after discharge. So I thought that was pretty strong. The weaknesses that there was very specific demographics, which may not be generalizable to other populations, other factors that could have accounted for weight loss, and more quantitative data were needed to assess patients. So the third study looks at, again, enteral nutrition in gastrointestinal cancer. So the objective of this study was to evaluate the effects of preoperative nutrition and immunonutrition on postoperative antibody and complement status for patients with GI cancer, as well as the effects on postoperative complication and infection. There were about 60 patients with GI cancer enrolled between January to December 2003, and they were divided into two different groups, IM and the control. And the immunonutrition group, they received a formula that contained arginine, RNA, and omega-3 fatty acids for 7 days before they even had their surgery. So then, after their surgery, they were given a standard formula that didn't contain those same things. Now, the control group, they only had the standard formula. They didn't have any nutrition beforehand. They only had that nutrition for 7 days after surgery, which was the standard formula without those omega-3s, RNA, and arginine. So the results were also significant findings that the preoperative enteral immunonutrition in patients with GI cancer improved the nutritional status, and the immunity decreased the incidence of postoperative complications and infections. So here's just what each formula consisted of. We have the standard diet and the supplemented diet, and you can see the content of what was in those formulas. And just a little bit about omega-3s. There's high levels of omega-3s can actually decrease the synthesis of PGE2s and inhibit the formation of tumor necrosis factor. And a high PGE2 level will also depress the cytotoxicity of macrophages, lymphocytes, and natural killer cells. The arginine can accelerate excretion of somatrophin, prolactin, insulin, and other hormones, which are believed to have had the function of promoting anabolism after trauma, and it accelerates the proliferation of T cells. So Table 3 depicts the characteristics of patients enrolled in the study. And there were no significant differences between the two groups in mean age, gender, or type of duration of the surgical procedure. The duration of antibiotic therapy for postoperative infection was actually significantly less days in the immunonutrition group versus the control group. Weight loss in the immunonutrition group on postoperative day 7 was significantly less than the control group as well. And the length of hospital stay was actually significantly less in that immunonutrition group. So the postoperative complications. The incidence of the stoma and fistula was significantly lower in the immunonutrition group compared to the control group. And the duration of antibiotic therapy for postoperative infection was also reduced in the immunonutrition group compared to control. I have this nice little picture here for us. These are little bacteria, and I have a little salt shaker pretending to be like the complement proteins that are getting onto the bacteria and kind of marking it and lysing it and putting holes in there. And that's kind of what these complement proteins do for us. And they were higher in the immunonutrition group compared to the control. And that was a significant finding. And they promote phagocytosis, stimulate inflammation, because we need that inflammation if we're going to be having an infection. That's our body's response. That's the defense system and against those different pathogens. The T cell subpopulation, CD4, CD8, what are those? Those are going to be also cells in the immune system that are protecting your body when you have some sort of pathogen entering. And in the immunonutrition group, you can see CD4 and CD8 were significantly higher than in the control group, which is pretty staggering. I have that little cute picture there. So figure 1 shows the serum immunoglobulin and complement that play an important role in the host immune function. IgG actually neutralizes pathogens such as viruses and bacteria by binding the key pathogen surface proteins and preventing the interaction of the pathogens with the host cells. And these IgG levels were also taken at baseline and at initiation and day 7, post-operative day 7. And you can see there's a significantly higher level in the control group before and after. This study, I gave an A positive rating. It was randomized and controlled, so that was pretty strong. Measurements taken, the dietary components consisting of arginine, omega-3s, IgG, all of that was really strong. It was non-biased. And the weaknesses, though, there was very minimal reportings on the studies. So I just think they should have talked more about what they could have done better. There's very limited commentary on that in their discussion. Really nothing. I couldn't find them talk about anything that they should have done better. But I do think that they should have measured the prealbumin and distributed a graph with that. So part 3, if there's any questions or comments anyone has, we can go into that at this point. Yeah.
In the last study, did they indicate why they looked at, rather than looking at the group without pre-nutrition, why they didn't give them a standard formula versus nothing? So it would have been a standard formula versus the immunonutrition formula. That makes sense. I said that very clearly.
So I guess, so they took, the first group had the early enteral nutrition and they had that supplemented formula. And then at the time of their surgery, after they had the surgery, they had that standardized formula. And then the other group had the standardized formula only after. And you're asking why didn't they have
the standardized formula beforehand.
Oh, right.
So you could actually see, is it calorie and protein, how much did that impact versus the immunonutrients, arginine?
Right, and yeah, that would definitely be like a weakness of the study. They didn't go into why. There was very limited discussion about their weaknesses or what they should have done. I agree, I think that's a weakness of the study and that should have been looked at or considered. But yeah, that would also rule out any biases and things like that. Yeah. Yeah.
Very interesting. That first study, I think it was the survival curves, right?
Yeah.
It was visually the group giving enteral versus parenteral looked different, but were they statistically significantly different from each other? They were both, I think, different from the control group. Is that right?
This one?
Yeah. Do you know if the enteral and the parenteral, they look different, but did that reach statistical difference between the two? Do you know?
Yes, it did. So the one on the green one was the enteral nutrition.
Yep.
Yes, they did, and it said that enteral was significantly different than the control, and so was parenteral, although enteral was above parenteral.
Okay.
Yeah. Yeah.
And I apologize, you may have said it and I just missed it. On the third study was the immunonutrition diet. Were the omega-3s a dietary change or a supplement for those patients?
Yeah, it was included in the formula.
Oh, okay.
Yeah.
All right.
And I can go back to that. There it is. Yeah. So yeah, I should have been more clear with that. So supplemented diet, that contained in the formula that they were given beforehand. But it is hard because some studies will use, we're doing a combination of maybe oral nutrition and enteral nutrition or parenteral nutrition or whatever it may be. So it gets a little tricky because there's so many different variables, I think. Yeah, it's like inception upon inception, right? But yeah, any other questions?
I have a question.
Sure.
Not specifically about these studies, but about your clinical experience potentially during your internship. Did you have experience, did you get to rotate in an oncology section or center or something like that? And I'm just wondering, I'm just curious, I have no clinical experience, so I'm just curious knowing or wondering what standard practice is in terms of enteral nutrition. Is it encouraged? Is there a protocol, and what are the downsides?
Yeah, that's a really great question. I think I'm actually in my oncology rotation right now at St. Vincent's. And what I've been told is that every place does things a little bit different. And right now, I think enteral nutrition is not pushed unless it really needs to be. Whereas at my inpatient rotation, I think that was used a lot more. But I think it's more, what can the patient tolerate? What are their needs? Do they want to do it? And then they might be in a later stage of life. So I think they consider more, quality of life. Yeah, definitely. Yeah.
It depends a little bit on the center, because some of the centers, if you have head and neck cancer, some places immediately it's just protocol to start tube feeding before you even start. Where I work at Theta Care, we have 6 questions we ask. And if you answer yes to 3 of those, then we do tend to go to the doc and push to start enteral feeding pretty early. So,
yeah, that's a good point.
She's right. Every center's different. So.
That's a good point. Those risk screens. That's another thing. There's so much I could have added, right? But there are risk screens that hospitals use, or they'll kind of tweak their own way. But yeah, they'll get flagged on that risk screen and be like, okay, well, maybe we need to start doing that. If there's a certain % of weight loss, maybe inadequate intake for so many days, things like that. But yeah, and perioperative, prophylactic tube feedings are also kind of utilized in that same category. You could explain that way more than I could. So direct your questions towards Rob, everyone. But yeah, thanks. Sure.
I actually had a question. So you said there's 3 pre-screening questions. What are
we look at age of patient. If they're over, top of my head, I think it's over 60 or 65. Stage of the cancer, size of the tumor, whether they're having dysphagia. And again, this is strictly head and neck patients. And the 6th one was, I'm not pulling it off the top of my head, of course. But basically, if we get 3 of those, and that was research done by a couple of our dietitians at the Cancer Center, looking mainly at male. And male, pretty much, if you're getting cancer there, if you're a head and neck patient, they give you degree before you ever start treatment. It's just almost a protocol for them. We didn't want to go that far. A lot of our docs don't want to start it that easily, but they're pretty good when the dietitians come and go, okay, this person is not doing well, and it's not, and with especially radiation to the head and neck, swallowing gets worse way before it gets better. And I think we've seen, for those people that do agree to get it pretty early on, and that's pretty important, because we've seen people lose 40 pounds and then decide to get it, because the patient often doesn't want it. Those that did get it early do better. But they get, we should show the studies, but a lot of the studies show that the better your nutrition is through any kind of cancer treatment, the better that treatment is. We have seen